let's introduce calcium channel blockers into this big equation. Calcium channel blockers work by, well, blocking calcium channels, right? So calcium channel blockers block calcium from entering our cardiac cells. So they're blocking off these calcium channels, and this is going to kind of suppress cardiac activity, kind of slow everything down. We're going to see a decrease in heart rate. We're going to see a decrease in contractility. We're going to see a decrease in afterload. So this would help our chest pain patient. All right. So we're going to see patients on calcium channel blockers at home prescribed, and we'll be giving one or two or three different calcium channel blockers just from our protocols as well. But calcium channel blockers block calcium channels. But we have two different types of calcium channel blockers. So we've got the big broad category. Now we're going to branch it off into these two little subcategories. We have dihydropyridines, which is a really fun word to say. Then we have non-dihydropyridines. So we've got calcium channel blockers, but what do we want that medication to do? And that's when we're going to give either a dihydropyridine or a non-dihydropyridine. Difference between the two? Well, the dihydropyridines affect vascular smooth muscle, so they affect the vasculature or blood vessels. Our non-dihydropyridines affect the heart. So if I just want to lower blood pressure, I'll give a dihydropyridine calcium channel blocker. If I just want to lower heart rate, I'll give a non-dihydropyridine calcium channel blocker. So one, our dihydropyridines are vascular smooth muscle, right? They affect vascular smooth muscle. And our non-dihydropyridines affect the heart itself. In practice, you're going to see your dihydropyridines and your non-dihydropyridines. Well, some examples of these, amlodipine or Norvasc is the trade name for it. Very common medication for your patient to be prescribed to control blood pressure. They might be on Norvasc to control blood pressure. That's a dihydropyridine calcium channel blocker, and we know it affects vascular smooth muscle. There's also nicardipine and nifedipine. You're going to see both of these drugs in the ER. You're going to see these drugs in the ICU. You're going to see these medications on the helicopter, on critical care trucks. Nicardipine, nifedipine given to, imagine that, control blood pressure, lower blood pressure. And these two drugs are going to be given IV. Norvasc can be given just PO every day. So patients not typically going to be prescribed nicardipine or nifedipine, but we're going to be giving these in the hospital or in a critical care setting. Some 911 agencies here and there might have these drugs to lower blood pressure. Then your most common non-dihydropyridines, these are typically given to control heart rate, to lower heart rate, because your non-dihydropyridines affect the heart, not the vascular smooth muscle. So diltiazem or cardizem is very common. You'll see that on the trucks. You'll see that in the hospitals. And same with verapamil. Verapamil given in the 911 setting here and there, give or take, definitely given in the hospital, and you'll see patients prescribed verapamil as well. So you've got patients with a history of these tachycardias, and we just want to keep them from starting in the first place. They might be prescribed verapamil, but our cardizems and our verapamils, these are our non-dihydropyridine calcium channel blockers. This bigger list, larger list of calcium channel blockers. There we go. So we've got verapamil, diltiazem, cardizem up there on the top. Those are our non-dihydropyridines because you see decreased heart rate, decreased AV conduction, decreased myocardial contraction. It's affecting the heart, primarily affecting the heart. The rest of these, your Norvasc, right, your nicardipine, your nifedipine, is right there. Arterial vasodilation. So what do we want these drugs to do? So we've got dihydropyridines, we've got non-dihydropyridines. Are we giving our calcium channel blocker to control heart rate, or are we giving it to control blood pressure? And so we know there's a branch in our calcium channel blockers. Which branch are we going to choose? Well, what do we want the end result to be? What's the problem with our patient, and what are we trying to fix?